Hello and welcome to today's Better Care Playbook webinar. The Paramedic Will See You Now, Expanding Access to Community-Based Care for People with Complex Needs. My name is Logan Kelly. I'm a Senior Program Officer at the Center for Healthcare Strategies. And before we get started, I'd like to just go over a few logistics. First, to eliminate background noise, audio lines are being muted during today's event. And there will be a moderated question and answer session following the presentations. Anytime you may submit a question online just by clicking the Q&A icon, which is at the bottom of your screen. Today's event will be recorded and shared publicly on bettercareplaybook.org. And at the end of the webinar, we'll ask that you please complete a brief online evaluation that will pop up on your screen. Your feedback is really important to us, and we hope that you'll take a moment to do this. Next slide. So today we are very excited to highlight community paramedicine and mobile integrated health models and to hear from teams at two different programs that illustrate the spectrum of what community paramedicine models can address, including providing urgent care and supporting home-based primary care. Next slide. First, we'll hear from Dr. Dan Henderson and Hannah McAbee with the instED program, which is based in New England. And then we'll hear from Dr. Amy Russell and Randy Fugate with Mission Health Partners, an accountable care organization in Western North Carolina. These two programs will each share insights about the designs of their program, outcomes, funding, and key implementation lessons. And then we'll have about 15 minutes at the end for our presenters to answer audience questions. Next slide. So with each presenter team, we are really fortunate to be joined by team members who serve as medical directors, as well as those who are leading community paramedics, to really understand how to design programs and teams to be most effective. Next slide. Before I turn it over to our presenters, I'll just provide some very brief background on the Better Care Playbook for those who may not be familiar. So the Playbook is an online resource center for evidence-based and promising practices to improve care for people with complex health and social needs. Every month, the Playbook summarizes new journal articles, evaluations, and implementation tools. And the Playbook also hosts webinars like this one and publishes case studies that are all designed to help translate that evidence and research into practice. And you can explore the Playbook more at bettercareplaybook.org. Next slide. The Playbook is coordinated by the Center for Healthcare Strategies through support from 7 leading national healthcare foundations: Arnold Ventures, the Commonwealth Fund, the John A. Hartford Foundation, the Millbank Memorial Fund, the Peterson Center on Healthcare, the Robert Wood Johnson Foundation, and the STAN Foundation. Next slide. And just for some high-level context on this topic before I turn it over to our presenters, community paramedicine and mobile integrated health programs provide urgent and or non-urgent care services in the home. These programs have a longer history outside of the United States, but are increasingly being implemented in the US with the goals of reducing unnecessary emergency department visits, hospitalizations, or readmissions. And as you'll hear more today, the scope of many of these programs is expanding. Some of the documented outcomes of these models include improved patient satisfaction and activation, lower acute care utilization, and with that, the potential for lower costs. And you can find more about this evidence and read other case studies of programs at the Playbook. Next slide. And now I'm pleased to introduce our two presenters who work together on the instED program. First, Dr. Dan Henderson, Chief Medical Officer, and Hannah McAbee, Community Paramedic with Cataldo Ambulance Service. Welcome, Dan and Hannah.
Hi, good afternoon.
Thanks, Logan. It's a real treat to be here. I'm a big fan of your work, and honestly, it's an honor to be presenting with Hannah, who is somebody that I'm constantly hearing from the docs who work for me and the patients is just terrific. So the summary you gave kind of covers all the highlights, but I hope we can get into some nitty-gritty here. And so I'll start with a very, very typical type of patient that we see. This is based on a real patient, though, of course, the name has been changed. And we see somebody with sort of roughly this kind of problem almost every day. That's by virtue of the fact that we care for people with very complex needs. And one of those complex needs is all that goes into living a normal and functional life with paraplegia or quadriplegia. And so a very common issue is infections, especially kidney and bladder infections. And for folks like Edward here, these can become serious or complicated either by becoming sepsis or producing abnormal changes in blood pressure due to the very different physiology of patients like him with spinal cord injury. Edward is really well known by his care team, and they understand what tends to happen with his body, as does he. But there's a real challenge in getting there on very short notice. And so one day, Edward is feeling sick, tired, chills, and he's really kind of run down and unable to care for himself. So he does what most of us would do, which is call his PCP. His PCP wasn't in the office that day, but the nurse heard the story and was appropriately worried and recommended that he go to the ED. Now, for a lot of us, the ED might be an inconvenience or kind of uncomfortable, loud, stressful, a lot of waiting. But for someone like Edward, where a lot of the things that make his life, very normal and functional in his home, his personal care assistant, assistive devices, having everything just right, when that's taken away, he loses a lot of his control and freedom. And so the suffering for him involved with going to the ED is much greater than a lot of us might be able to imagine if we haven't been affected by this kind of issue or had a loved one who has. Now, luckily, Edward is so plugged into care and so knowledgeable about this that he's developed kind of a sort of righteous attitude. And so he doesn't call 911, he actually refuses because he knows that there's this great service out there. So he calls his care partner, his kind of go-to problem solver, who arranges an in-home visit from our service later that day. So Hannah will tell you how that goes and how that has gone for her many times. But before, I want to lay some backdrop and talk about our processes. So my company instED was created in 2018, but the problem that we're here to solve has existed for much, much longer. And there's two parts of this. First is access to urgent care for the most vulnerable. There are a lot of ways to think about who's vulnerable and who's not. Insurance is a useful marker because it's very crisp, but there are so many other ways to think about this. But we know that patients with Medicare, Medicaid, or both benefits are much more likely to have ED visits and much more likely to be admitted. And these are the populations that we tend to care for because payers will ask us to help serve their members. And then we also know that complexity plays a big role. So people who are more likely to need care and also have greater difficulty accessing it in the conventional places, like an urgent care clinic or a primary care office, those are the ones who represent a huge unmet need for immediate urgent care, or sometimes we say unscheduled, when it may not be exactly urgent, but it comes up at a bad time. The second problem is the lower value associated with a lot of the hospital-based care for these patients. So I like this definition of value, which I took from Virginia Mason Medical Center: appropriateness times outcomes plus service over cost. There are many, many ways to think about this, but the key thing is you really have to think about the outcomes that you're achieving for a patient and the cost or resources needed to achieve them. So we know that unlike a lot of parts of the hospital, for example, surgeries that return function, many of our ED visits and admissions where the diagnosis is unclear, the improvement is sometimes unclear, they do tend to be somewhat questionable value at times. This is not to knock the clinicians who are saving lives every day. And certainly if you have a heart attack or a stroke, the ED is the place to be. But we know that about 40 or 42% of ED visits, according to the Mass Health Policy Commission, are avoidable. We know that about a fifth of people who get discharged from the hospital end up back within 30 days. And we see a huge amount of variation between hospitals across different practices that suggests that at least some of the care is probably not due to biological factors. And just as an example, the rate at which people are admitted for chest pain varies by about 60-fold. That's a huge differential. And this matters not so much because we have a problem with people getting care in the hospital, it's just that it is so expensive and we all end up paying for it. So when someone like Edward develops an urgent problem, we know that it's likely to cost about $3,000 on average, no matter if you take all the different paths he might take. So this begs the question, where should people get urgent care? And for most of us who have a different health situation, it's very appropriate to go to the clinic when you're not that sick and the ED when you're very sick or not sure. But for many of us, these are not great options. In many cases, the convenience factor or the experience really do matter. And the ED is a great place to go if you're really, truly quite sick, but there's a tremendous amount of harm as well as waste. And again, for someone like Edward, where a fall or an infection or delirium could really take a toll, the ED does tend to be a bad choice for things that are not the highest severity. And so that's where care in the home comes in. Care in the home is often the best experience, and it's not just not having to travel, it's meeting a healthcare provider on your own turf and to some degree on your own terms. And most of the models that I'm aware of, and certainly ours, can do more in the home than most clinicians in an urgent care office can. Things like IV medications, rapid point of care testing. So there's also a benefit there. If you go to the clinic, oftentimes they'll say, well, let's check your labs and we'll get back to you in a day or so. And that may not work for someone like Edward. So in 2014, our parent company decided to launch a pilot that was called Acute Community Care. And the idea here was that paramedics were this untapped resource, kind of a secret weapon, because they have this tremendous ability to instinctually know who's sick or not sick. And we believe, Hannah can speak to this, that they really wanted to be doing things differently in many cases than just grabbing people and bringing them to the ED. And that they like being involved in a sort of different flavor of care. And so this program was created initially to run after hours and was seeing just 1 or 2 visits a day, 1 truck and 1 nurse practitioner fielding the calls, but gradually grew and had seen about 2,000 visits by 2018. And when studied, the patients who were seen in this program to a statistically significant level rated the care as higher quality and the decisions more likely to be right. And the savings are difficult to estimate because the founders of this program didn't randomize, but were estimated to be pretty significant, as you can see here. And that makes sense because when people like Edward go to the hospital, it's very hard not to admit them because of all that is going on and how complex their medical and non-medical factors are. So after 2018, our parent company decided to spin us off as a wholly owned subsidiary. So we're sort of free of the nest and on our own. And we've grown a lot over that time. You can see about a 10-fold growth in periodic visit volume. And we've expanded to cover Massachusetts and Rhode Island. And this is not the super fast expansion that you might see with like a Netflix, but this is much faster than most clinical things grow. And so doing that safely has been an interesting challenge and something that I think we've done well. Here's how our process works now. Our visits go from 10 a.m. to 10 p.m. And that's because we learned that patients don't really want you coming at 3 a.m. They would sometimes close the door and say, could you come back in the morning? We take requests online through a hotline or through an app. And then these are reviewed by senior ED nurses, people with 10 or more years of experience. And they're reviewed to figure out how urgently do these patients need to be seen, and especially to make sure that we're not seeing somebody who really does need the ED and only the ED. And then a paramedic like Hannah is dispatched from one of our paramedic partners. So Hannah works with us, but not as an employee of instED. And that I think is a key part of our ability to grow. It's hard to find and hire paramedics. So working with different companies gives us some advantage there. And it also means that the other medics in Hannah's company are able to work for other customers or do the conventional EMS if the demand is there. So that flexibility is important. We see people in 1 to 3 hours for the highest acuity visits. So not the 6 minutes that Hannah might achieve when she's on a true ambulance, but very short wait. And Hannah would do the in-person history and exam and some diagnostics, as you'll see, and all the while is in contact with a physician by phone or sometimes video to discuss what she's finding, what she thinks is going on, what might be the most appropriate treatment. And then the 3 or 4 in this triad, the paramedic, the physician, and the patient all discuss what feels right in terms of going to the ED or treating at home. And then there's follow-up the next day by our team who calls to check in. These are some of the cool tools that Hannah has at her disposal. A point of care blood analyzer that can do 27 different analytes in under 20 minutes, the ability to get EKG and have cardiac monitoring, and in many cases, an ultrasound, which is mostly used for access to veins to place IVs and draw blood. These are the kinds of things that we treat, as I think many people with a clinical background would expect. Acute illnesses and symptoms, especially infections, chronic conditions that are flaring up, and injuries that are unlikely to need imaging. And we do point of care testing. We send off blood and urine to labs. We can do IV medications and fluids, and we can give oral medications, nebulizers, and things like that. It's important to mention that this would be very hard to do with sort of purpose-built system. So we have an operating system that we built that we call instED now. You don't have to have this, but as we've scaled, it became harder and harder to do this through sort of an email-based system or almost like a survey. And this has really helped us be able to get everybody where they need to be. It's a lot like DoorDash. So there's a platform for Hannah, who needs to know where to go and what's going on with the patient. There's a platform for me, who's going to be on the phone with her and wants to know what the patient's vital signs are and what's going on. There's a part for our nurses who are seeing all the visits coming in and kind of doing air traffic control. And it all captures the clinical information and makes sure that it gets where it needs to be. We're really proud of our results. So 90% of the people that we see we're able to treat at home and not send to the ED. And keep in mind, most of these people, the vast majority, have been told that they should go to the ED by some other healthcare provider. At 3 days, which is kind of our ideal interval, 85% remain hospital free. But at 7 days, that's 82%. And at 14, it tends to be in the high 70s. Because of our ability to avoid ED and hospital care, we estimate a $1,900 per visit savings, almost $9 million for our customers in the past year. And patients really love this. And some of that is Hannah and her colleagues who really just do a wonderful job. But a lot of it is also just the benefit of care in the home, which really is hard to describe until you see it. And importantly, we've looked to see if we're worsening disparities like so many innovative parts of healthcare unfortunately do. And we think the opposite is true, that patients from historically marginalized groups seem to get instED visits more often than others, which we're glad about. In terms of the quintuple aim, we also can do overdue screenings. Hannah may notice things in the home that nobody would know about without someone there. And we think we're also making the lives of primary care teams a bit easier. So there's a lot of challenges, and maybe we'll get to these in the questions, but financing is tough. And we have to do this from a separate per visit fee because there just aren't codes currently that would come close to paying for this. Communication is a challenge, and you have to have the right team members and sort of the right relationship to be able to trust and talk to each other. And we think a lot about the highest utilizers and how much risk we're taking, but we think we have the balance just right. So I've sort of told you about our platform. I'll pass it back to Hannah, who would be in the home and will tell you what she would find and do.
Hi, thanks so much. So typically I would be dispatched to Edward with someone saying, listen, Edward's feeling unwell and is having symptoms that are similar to when he's had UTIs in the past. I went to Edward's home and found that he was laying in bed and really, really anxious that I was going to go to him and say, listen, you have to go to the hospital. And he was actually in tears at the time. So I gave him some emotional reassurances. I'm going to do what I can and do an evaluation, and we'll see what happens. So what I found was Edward saying he was having lower abdominal pain. He was really fatigued. I performed a set of vital signs, found that he had a low-grade fever, which he was unaware of, and consulted our online medical control doctor, who ordered me to get point-of-care lab testing to check his kidney function, and also to get a urine sample. So I was able to obtain urine doing a straight catheterization, and performed a urine dipstick. I found that urine, actually you can do next slide, excuse me. I found that urine was cloudy, there was a foul odor to it, and it was really dark. And also the point of care testing with that labs found that his kidneys were actually in pretty good shape. He was not in kidney failure at that time. So I reconsulted our doctor, who had then told me to give 1 liter of normal saline to infuse and a gram of ceftriaxone antibiotic. And he was just so relieved that he was getting treatment at home. I was also ordered to send that urine off to the lab to culture to see if it was susceptible to the antibiotics that he was about to be prescribed, the oral antibiotics he was going to be prescribed. So some things to consider with Edward's anxiety, which I completely understand, is he had had some previous negative experiences in the ER in the past. Usually his ER trips resulted in hospitalizations, which can come with some complications. In Edward's situation, being a paraplegic, his primary caregivers at home, or his family, were home with him all the time. They were able to readjust him to prevent any kind of bed sores or ulcers. He was really concerned that if he went into the hospital, that he was going to develop pressure ulcers from being in bed all day without his care providers being there to help him. Another thing he was worried about in this age of COVID was the fact that he could get additional diseases like COVID or pneumonia, something else that would further complicate his medical problems at this time. So after all was said and done, and he received treatment, he received IV fluids, we sent his urine off for culture, and we had a plan in place. He was so relieved and felt like he had been heard by his care team, by his providers, by the medical control doctor that we had, and was just really grateful that he was able to stay home at this time. So while performing these treatments and giving this care, we also went over some patient education, increased your fluid intake, symptomatic treatments like Tylenol for fevers, and went over what we call red flags, which are reasons that would trigger an ER visit that would make this situation become emergent and that he would have to go to the hospital for further treatment. And he and his family voiced understanding, and they were set to get follow-up from a nurse the next day. So ultimately, I feel like this was a success, this visit. And he was just really grateful. The family was really grateful, and it was really gratifying to be part of his care. And so that was my visit with Edward.
Well, thanks, Hannah. And I think that's all we've got for you folks, but we're looking forward to your questions. And again, it's a pleasure to be here, and we're fans of the work that the Better Care Playbook is doing.
Wonderful. Thank you so much, Dan and Hannah. And we've already gotten some great questions. Please feel free to write in your questions in the Q&A. And next, I'm excited to welcome Dr. Amy Russell, Medical Director with Mission Health Partners, and Randy Fugate, Mobile Integrated Health Manager with Mission Health Partners. Welcome, Amy and Randy.
Hey there, thank you so much. It's great to be here today to talk to you about our Mobile Integrated Health Program. I'm going to see if I can advance the slides. So Mission Health Partners is a Medicare ACO. We manage a variety of different populations through contracted arrangements. We are a network of physicians in Western North Carolina, 3 health systems, and it's over 1,000 physicians, over 100 tax ID numbers, independent practice, post-acute care facilities, and all working together to care for patients in Western North Carolina. And we've been a Medicare Shared Savings Program since 2015. Because, as you could see, the geography of Western North Carolina is mountainous, and for individuals with transportation difficulty, it can be hard to get to your provider. That is one of many issues we've been trying to address as an ACO in order to meet individual needs and to make sure that people are getting access and quality care. Over the years, we've developed a team approach to care as an ACO. So we have team members who are really focused on addressing gaps in care and quality, a care coordination team of nurses and social workers who are outreaching related to transitions and chronic condition management. And then we have a community engagement team that includes our mobile integrated health team that is out in the community addressing needs, screening for social determinants of health, and doing care with the mobile integrated health team and the CaraMedic team in the region. So we have our team divided into pods, and they serve specific practices and specific regions and partner with local human service organizations to provide support for members of our community. So this is our interprofessional team. We have physician leadership, we have nursing, social work, pharmacy, our community paramedics, which we call our CaraMedics, and then we have resource specialists who are often embedded in practices, but also may do telephonic work as well. And then we have a group of community partners that we collaborate very closely with. some not listed here we also collaborate with, but with every interaction that we have with a patient, we do a social needs assessment, and many of those needs can be addressed by community organizations. And so as we built our model of mobile integrated health, it's important to understand that this was a really key element to that, because many of the individuals that we're serving that are high risk have a lot of social needs. So this is the history of our mobile integrated health program. So it started as a part of our regional transport system. A group of CaraMedics were trained, and we developed this capacity within the regional transport system to do visits for high need patients, working closely with the emergency department to identify patients who were infrequently with the emergency room. Through that evaluation and some local evaluation, we were seeing a positive impact on utilization. So the program grew, and we actually brought the program under the fold of the ACO in about 2018. With that work, we started collaborating with another program, home-based primary care program locally, to provide support to home-based primary care. And the CaraMedics played as an extension to that team. And then in 2020, when we started to experience the pandemic, we started to expand the role of the CaraMedic to do outreach to people who were not accessing care and develop a process around telehealth connection with their primary care provider, their specialist provider, to provide health. We also began to do some other things like COVID vaccines for home-based patients. And in that same period of time, we contracted with Medicaid payers and started doing pediatrics as well. And then most recently, we added a respiratory therapist to our team, and we have a COPD program that our mobile integrated health team is very involved in. So just to look at the full picture, I think I mentioned that initially we were starting with high patients who are in the emergency room a lot, or utilizing services a lot, and trying to address that need. We identify people through our population health platform and risk stratification. We're looking both at high risk and utilization. And most of that original work that we're still doing is around transitions of care, identifying people who need support after hospital discharge. The team does med reconciliation. They can do telehealth support at those visits, support home-based primary care patients. They can do full clinical assessments, medication administration, assist patients in choosing the most appropriate care, and coaching around the use of their durable medical equipment. Also, as I mentioned, in the pandemic, we started to do outreach for people who were not accessing care. So that is also something we identify through our data. We can identify people with chronic illness who were not getting in for care. And so we started to develop the capacity to do telehealth visits for wellness, so do annual wellness visits and other clinical assessments with the partnership of the paramedics. In the state of North Carolina, the mobile integrated health program is considered an alternative practice model. So the paramedics can work under the license of a physician and deliver care as deemed necessary under that model. So I'm going to hand it off to Randy Fugate, who's been a great partner through all of this and really the lead of this team and does a lot of the work himself, and have him talk a little bit more about this and talk a little bit about the direct patient care aspect.
Want to hear me?
Here, yeah.
Perfect. You can go to the next slide. So much in the same fashion that Hannah mentioned in terms of delivery to care in the field and things that we're able to do, Dr. Russell just mentioned that we're designated as an alternative practice setting. We're a little bit different, although our roots are certainly well-grounded in 911 EMS response, and then later on in critical care transport for both pediatric and adult patients. We still have our roots very firmly embedded in 911 care, and out of that grew the work that we're doing. Our staff, and you can see on the slide here, the certifications that what we require, what we hold to be important include, of course, being a state paramedic, uh, IBSC, and I saw that Hannah has the CPC designation also. We require CPC or community paramedic certification through the International Board of Specialty Certification. Of course, National Registry of Critical Care and adult and pediatric critical care. We also added, Dr. Russell mentioned social determinant-based considerations, and we have found that this is key in being able to help these patients develop goals that are achievable and measurable and also adaptable to where we can keep shepherding them along through things that they feel is important to them, while also, if you will, nudging them along into things that will improve their quality of life, reduce unnecessary utilization, and when utilization is necessary, really direct them to more appropriate resources for those services. Anyway, going back to what I was saying, we engaged in crisis intervention training and community resiliency modeling training, which has taken on a new moniker now. I believe it's called Resources for Resiliency. Anyway, these things really empowered us to better understand and better work with our patients and really kind of meet them where they are. Critical incident stress management training is something that's kind of unique to fire, EMS, law enforcement, where when they go through some terribly traumatic line of duty death thing, or there's a lot of parallels really that carry over into the PTSD and other things that we find that our patients are suffering. And there's some real tie-ins or parallels to critical incident stress, again, with some of our patients. We can go to the next slide. So I want to tell you a couple of patient stories. The first one's a 74-year-old female who suffers with COPD, nicotine addiction, and rather complicated insulin-dependent diabetes. She is a very loyal customer, a frequent utilizer to the emergency department, and as such, she really challenges the local fire and EMS folks in terms of transportation resources and emergency response because, as you can see on the slide, prior to her engagement, she was using the hospital in one way or another. About every 15.6 days, she was either in the emergency department or occasionally being admitted. She had, and these were all for acute respiratory failure. She has a really, her social situation for this patient is kind of mixed in terms of family support. And among the assessments that we do, we really look at a lot of social determinant-based considerations because that helps our collaborative team with the social workers and the nurse care managers and the resource specialists, all of this team. If we can really understand what's going on with these folks in the home, we often say that we don't know what we don't know, until we really know. And there's so many things that are unknowable if we're basing the situation on what the patient's telling the physician or the mid-level provider or other stakeholders, what they're telling them as opposed to what we see in the home can be vastly different. And I would imagine Hannah would agree with that. We often find things to be a great deal worse, but sometimes a great deal better than what is assumed. Anyway, going back to our patient, she required CPAP, and when we as part of our assessments, we were looking at her DME, and her CPAP was filthy and essentially unusable. It was mold contaminated, and honestly, using that device would probably have made her a great deal sicker than what she was. There were a bunch of fall risk hazards that were identified, and some real simple opportunities to mitigate those things from becoming yet another reason that she would need to go to the hospital, and certainly that she would suffer some kind of injury or mishap. So through engagement with the CaraMedic, and we worked collaboratively with our respiratory therapists that Dr. Russell mentioned, the care manager, the nurse care manager, community resource specialist. This collaborative team really came together and were able to get replacement her CPAP. It's clean and everything is operational and works as it should. Um, Another thing that we do is a very robust medication, or not really reconciliation, although we have pharmacists that can help us formally reconcile medications, but a really robust medication inventory. And we are all the time finding patients that are taking medications that are the improper strength, or they're taking duplicate medicines. We found a patient that was taking 360 milligrams of Lasix a day when she's only supposed to be taking 80. But she had gotten prescription from 3 different providers, 3 different pharmacies, and none of them knew what was going on. And without that in the home view of her situation, potassium, I think, when we had her transported because she was terribly sick, but I think her potassium was 2, if that. Or I'm sorry. Her potassium was very, very low, around 2. Anyway, she was kept in the hospital and recovered just fine. But without that in the home view of it, it could have been a terrible outcome. We see a lot of folks and particularly this patient that we're talking about here. We were able to help her manage with this collaborative team some complex conditions, and really immediately address some of the things that could lead her going back to the ED or being readmitted. But really, the most important thing, and this is the thing that we kind of hold dear, is this improved this lady's quality of life. She got things she needed. She could breathe better. She wasn't as sick. She wasn't going to the hospital all the time. So this we feel like this is a real big win. We can go to the next one. This patient's a 68-year-old female who suffers with morbid obesity, atrial fibrillation, diastolic heart failure. She has a very complicated GI history, which includes bowel incarceration, which has led to an anterior fistula and ostomy. And this lady too and her social situation a great deal more complicated because she doesn't have family and supporting friends, and through her acuity, there's some reluctance among home health to engage with her. There's also a great deal of reluctance on her part to go to any kind of long-term placement. Anyway, there's some denial of home health. And this patient lives in a trailer alone. Not a great living situation. She again, just like the other patient, calls EMS quite a bit. I already mentioned the unfortunate social situation. So the issues identified with her was she had really compromised access to her medications. She didn't have anybody to go get them. She didn't have a good relationship with the pharmacy, and now a lot of the pharmacies here will deliver medications, but it required a lot of shepherding to connect the dots to make some of these things happen. She had virtually no ostomy supplies, and the initial situation discovered was dismal. She has little, if any, access to transportation, and particularly short-term transportation, which led to a lot of missed appointments, and even specialist care really had divorced themselves from her situation just because of no-shows. Again, home health services perceived her, and maybe rightfully so, but she wasn't going anywhere, and quality of life was terrible. So the CaraMedic visit really included all of the things that we mentioned, our standard assessments. It allowed us to collaborate with the nurse care manager, who was really key in helping put some of these things together, and then the resource specialist and other folks able to come in, pharmacist very, very much able to help kind of comb through what she's supposed to be taking versus what she has, and figure out some solutions on getting her medicines to her. This resulted in a great deal of improvement in her home situation and her risk of infections through this ostomy, and it led to decreased EMS and of course ED utilization, really reduced risk because we incorporate all of our standard assessments for every patient. We can pick the things that don't really apply, but pretty much everybody gets fall risk, home safety, medication inventory, and assessment of food security. And although it's not on the slide, a measure of her social determinant of health status, and all together looking for gaps that can be addressed and offering opportunities to make our life better, and also to help contain our costs and also their burden on local emergency services. We can go to the next slide. Anyway, the point of this slide isn't really to compare one to the other, but really to articulate that when with the group that we measured with this particular information, we wanted to illustrate the sharp decline in their ED utilization before and after the CaraMedic engaged. And it wasn't all medication in as much as it was just sorting out what they have and really being able to provide intelligence back to the other stakeholders to make informed decisions that were really accurate. Going back to what I said earlier about their perception of normal in their home situation, we find it amazing what some people can perceive to be normal, because that's where they live, regardless of the threat to their health and safety. The next slide. But anyway, this really does illustrate a big decline in their ED utilization, and as you can see, it sort of planed out for a bit, and then the decline continued on as we learned more, and as we engaged more, and as more of our collaborative team really engaged with these patients. It really yielded a great deal of benefit to the patient. Go to the next slide.
I'm sorry. Sorry about that last slide. It looked like there were some formatting issues. Just to close with some lessons learned, obviously Randy has illustrated the importance of the multidisciplinary team and how important that we found that in the success of this program, not just in addressing the high-risk chronic conditions, but also getting upstream and addressing needs for people who aren't accessing care. The importance of that relationship the CaraMedic has to address social needs and to develop an effective care plan. The model requires a lot of resources, time, and relationships. This is different than just an acute care model, though that is incredibly important. This is something that we've had to develop over several years and are still developing it. The resources come from care management fees and from shared savings, which we've been successful with very consistently, so that has helped the program. We do know from evaluation that we have impacted utilization and cost in the population served. Those programs are very difficult to evaluate, sometimes because of population size and the number of different variables that can impact outcomes. And then what we consider in terms of investment within ACOs, there's a lot of ways to invest in impacting your performance. This is something that it requires a lot of investment over time. We always felt that it was important to look at the long-term impact on the community and something that could be long-lasting in terms of a resource that would serve the people who need it the most. So with that, I will close, and I know we have some questions to answer. So thanks so much.
Excellent. Thank you so much, Amy and Randy. We've been continuously receiving lots of great questions. I'd like to invite now all of our presenters to come back on screen to answer some of those questions. And for those who haven't submitted yet, you can submit those on the Q&A icon at the bottom of your screen, and we'll do our best to answer as many as possible. So I think one of the most common questions that we've heard relates to funding and sustainability. So I'd like to invite first Dan and Amy to speak to what you think kind of some of the challenges that you've experienced with sustainability and some of your thoughts on the sustainability models beyond grant funding to keep these programs running.
I'll start. So we're not grant funded. We are, our costs are covered through negotiated care management fees, which not every payer, and obviously MSSP, we don't have care management fees. And then through accrual of shared savings. And I think the main thing I would highlight is with a physician-led board, a community board, local region, having that commitment from the clinicians locally to invest in this model has been critical to the success. Because that may not have happened if that hadn't been a commitment. Instead of distributing it in other ways, reserving that money for the care management has been really essential.
Yeah, and I'm not a healthcare finance expert, but grant funding would be a great way to get something off the ground or fund something that can't otherwise be funded. And I mentioned in the comments New York City's Be Heard program, which involves acute behavioral health intervention. They spend $30 million a year, but almost certainly to a great use. But it can be hard to find that kind of funding. And when it's grant funded, it may run out or may not be able to scale or grow. And one of the challenges with this model is that it's so different. It does take a while to get momentum and have, in our case, primary care teams, usually nurses, understand how to use this and have a good experience with it. And I'm a doctor. Doctors are very grouchy if something doesn't go right and may abandon something for kind of irrational reasons. So you really have to have stability in your ability to grow. That I think grants provide really good initial stability because you don't have to justify a profit or anything, and we lose money, so we're not making a profit. But it does make it tough to grow, and if you can't grow, your users will get frustrated and leave. And I think a lot of hospitals and other health systems are doing this, but they're not able to get funded in many cases because there aren't good billing codes for this. So they will tend to use either a nurse practitioner, which is a higher cost resource, and use a home visit code, or they'll use a video visit code for the video visit part. And those help a little bit, but really are way below what it costs to provide this service. And we don't know what it costs everyone, but we know that we are doing this for cheaper than a lot of other services. So it's really tough to make this work without kind of getting paid a special fee for the visit.
Great. And then a question that I'd like to ask Randy and Hannah to speak to are just kind of what's one top of mind consideration for how to build the right team of community paramedics, and especially in light of some of the challenges with current workforce shortages.
Okay, I'll go first. So I think building the right team of community paramedics comes down to finding people that care about people. Like, I think that all of us in healthcare care about people. We have to. This is why we're here. Paramedics that are doing community paramedicine now are I feel like a different kind of provider, where we are putting ourselves in their spot and saying, all right, what can we do to make your life better, not just in today's visit, but moving forward, what can we do to set you up? And finding that kind of provider is going to be a challenge, but I think we're all out there. I think that this is going to be a new type of EMS. It already is, we're getting into the ground floor now. This is going to be a new subspecialty of EMS, and we have to grow our providers.
Thanks so much, Randy. Anything that you'd like to add?
I would echo what Hannah said, and add that I was EMS director in a nearby county for several years, and we did a lot of research on our utilization and those kind of things. And although we don't really tell the commissioners this, 77.34% of the time that we ran emergency out to a call, any call for service on the ambulance, that call could have been handled by a good evaluation and by some strategic thinking to get them to a better place than the emergency department. Now, and I don't know about what the state or the environment where Hannah works, but it's really just now coming along where we can make those alternative destination decisions, and we're not tied to the ambulances anymore. But all those years, as a paramedic and as a director, we often would say, man, if we could just do this one thing, then Mrs. So-and-so would not have to go to the wrong place for the wrong reason, a great deal of expense, tying up a county resource, tying up an ED bed, and really, although we didn't think of it then, the cost of doing that, it was just the wrong thing at the wrong time, all of the options. So I think that being able to, particularly for somebody that's been doing this for a little while, there's a lot of reward. And you to your point about staffing shortages, they're clearly terrible, and particularly in EMS, they're terrible. We do have some things to offer in this discipline in community paramedicine that will resonate with people that have been doing it for even for a little while, because they want the ones that are intelligent and want to do more, and really, as Hannah said, caring people want to provide care in a unique way. So I think we're in a good spot in community paramedicine, and maybe a better spot than regular 911 EMS.
Thank you both so much. And we've received a lot of questions related to behavioral health. And I know some have already been answered in the Q&A, and then, but I wanted to give a chance for everyone to speak to those, including another question that just came in about if you've seen any ability of these programs to work with individuals who are dealing with substance use coupled with homelessness. And I would just love to open it up to anyone who'd like to speak to either the experience you've had in how these programs work with individuals, either in behavioral health crisis situations or with serious behavioral health conditions, or the opportunities that you think these programs may have going forward in working with those populations.
Well, I'll say I think this is a great opportunity. You know, medics are frankly very brave and comfortable going into the homes, or in some cases not homes. And it's obviously one of the biggest needs in America. You know, we see a lot of patients who are experiencing behavioral health issues, but we tend to see them for some kind of medical concern. And any ER doctor would tell you that this is also the way it happens in the ED. I think there's been more sort of willingness to name behavioral health issues recently because of reduced stigma in the setting of COVID and us all having them. And, you know, we are looking at, but we're trying to be careful and thoughtful about a few things. The biggest opportunities I see are medium risk suicidality, but not the highest risk. The highest risk we could do if we had a secure linkage to a crisis stabilization unit. And I would love to do that, but I don't want to put anyone in harm's way. And then opiate use withdrawal is a huge opportunity. People go to the hospital, they're intoxicated or withdrawing, they get sent home, and there's a magical moment where we can help them get treatment. And that's a place that we really want to go into. Alcohol withdrawal is very, very scary because you can look great 1 minute and the next minute be having a seizure. So we've thought about that, but I think it's too dangerous, and except for the low risk folks, and we could still provide some benefit there. And then I think also a better linkage to longitudinal behavioral health care. And we have pretty good linkages, but not so secure that we could guarantee people can get plugged in. But I think that would help for practically everyone, but especially for people who are experiencing sort of crisis or one level below that.
I'll just add a couple things. So at the beginning of this program, a part of our funding was from the county to support people who are homeless. And that is the original evaluation where we saw a pretty significant impact. So, and I think it's part of why we included a lot of behavioral health, CRIM training and things like that in the development of this program, because we felt it was an essential skill that the team needed to have. We don't do all of the work in the region. I think out of this program we've partnered with other entities to develop other programs. So we have some other local programs that do acute care opiate use disorder management. That's been really great to see that people are thinking more creatively about this model now that people are starting to understand the impacts of that. And you know, I don't know, Randy, if you have other things to say, but I think this is absolutely right. Sometimes we don't go to a home because we understand that there's a behavioral health or a mental health problem, but that often ends up being some of what we need to provide support with.
I would just add that I certainly can't quote statistically, but it seems reasonable that every person that has multiple comorbidities, if you will, there's always a mental health component to that, if nothing more than some level of depression. Now, granted, we've gotten into situations where it was a great deal more severe, but there are also resources here with mobile crisis. And could it be better? Certainly, it could be better. It could be better all across America. But we have been able to identify some things and some opportunities, and with our social workers here who are just wonderful, being able, whether it be me on the phone or me or one of the other folks out, being able to access that level of mental health support in the moment to at least disrupt what's going on and try and get them to a safer place, I think is really important. But also looking a little bit deeper in each of these people, particularly those with complex medical issues, and asking the question, or at least suggesting and collaborating with the providers to say, have we considered depression as being a real serious part of this now that we've had to look at the home environment and the social determinant-based considerations?
Excellent. Thank you all so much. We have a number of other questions that we unfortunately won't be able to answer all of today. We will be posting the slides and linking to relevant resources on the webinar page. So you'll see that shortly. I'd like to also just invite everyone that if you've developed evidence on what works when caring for adults with complex health and social needs, please feel free to submit any resources and ideas to the playbook. We really welcome those submissions to help to spread best practices in complex care. And finally, to please fill out the evaluation survey that will show up on your screen at the end. We just really use and value that feedback, and it helps us publish content on the playbook that will meet your needs. So I want to close today by just thanking all of our presenters who shared such great insights with us about their work. We really appreciate it. I'd like to thank the Seven Foundation Collaborative for making this webinar possible, and everyone who joined us today and shared your great questions. Thank you so much and have a wonderful day.
Thank you. It was fun.
Thank you so much.
Thanks, everyone. Take care.